Well, let's now turn to the ambitions to improve interdisciplinary collaboration and, of course, next steps. What should they be in our journey to improve patient care? Because that is what this is all about. Let's bring in Professor Salmi now. So we know we have to get interdisciplinary care to work. What does it look like to you, best case, when accounting for type 2 inflammation?
It means that the patient gets the diagnosis of all type 2 diseases fastly in the center or in the healthcare unit, usually the hospital outpatient clinic. And not just that, but that the severity is assessed, and then the treatment is planned together with the professionals, and the patient really feels that sometimes, for instance, CRS with nasal polyps and asthma, there is one having bad exacerbation, or the exacerbation might be more in the lower airways, and then after some months it can be worse in the upper airways. So the best option is that the patient, when he or she visits the doctor really can take or give advice or understands both the asthma and CRS with nasal polyps, and can treat both and diagnose the bad situation and make a consultation fastly.
Can I bring in the other two professors, Professor Cardell and Professor Smith? Do you want to add anything to that particular answer?
Yeah, I think there is a general awareness that you should look beyond if you're an ENT, beyond the nose. But I think what's often missed, I think even what sort of lack of awareness is the global overreaching symptoms outside the specific organs, like the sleep disturbance, absence of work, the social isolation that we mentioned before, learning difficulties, and the mental problems, the depressions. I think that's something that's even in these good cases when we come together, pulmonologist and ENT, for instance, we often miss sort of this third set of questions outside our own specialties.
Okay, thank you very much indeed for that. I want to bring in Professor Smith here. Clearly, we've heard a lot there from the other two experts. For you, though, what would typical treatment pathways look like? So if we're trying to bring everyone together, and we heard Professor Cardell say there, you know, it's about the depression, it's about all of those things that sometimes we as clinicians don't sort of, or fail to recognise. I think we're so busy sort of treating symptoms that we don't treat the other things, and we don't treat people as human beings.
I think the white papers do bring up these issues that affect people's quality of life, and it gives us the opportunity to discuss those, as has just been raised by Professor Cardell's, discussing poor sleep quality, discussing anxiety, depression, loss of work, helps give the patients a realisation that you get it, that you have empathy, that you're working together for the goal lines, not just to improve the skin score or the rhinitis polyp score or somebody's lung function. It's looking at the whole picture of quality of life, and gives us new goals to focus with those patients with individualised care.
Yeah, I think it's really exciting when you're bringing all these teams together and actually looking at the person as a whole and understanding that they're not just, you know, they don't just manifest clinical symptoms, that actually they have to be treated as a person. I want to bring in Stefan Geisels now, if I may. I'm sorry, you've been quiet for a very long time. Now, we've long understood that patient voices are critical. We've seen, obviously, 2 different patient-led publications from EUFOREA. I know these have reached something like 9,000 views in science journals. We also know that everyone from, say, physicians, researchers, pharmaceutical industry and policymakers are always looking for answers about treatments and meaningful solutions. So for you, as an advocate for patients, where do you see this? What are your thoughts so far?
But I think, first of all, the guidelines or the recommendations in the white paper are not very different from what we see in other diseases like cancer, rheumatoid arthritis, multiple sclerosis, and others. Very often our healthcare system is built around the clinical interventions during the patient pathway. And not much attention is being paid to the consequences of the disease or the consequences of the treatment itself. And I think that is where the voice of the patient should be better organized and develop value at a higher level than it does today. And that's why we are trying to organize patient organizations to take a complementary role to the medical system, so that patients after diagnosis can be referred to a patient organization with knowledge about the entire complexity and diversity of their patient population, so that they can help patients with all the non-clinical aspects of the disease, like the psychosocial environment, the professional environment, or studies if they're young. How do you cope with your disease? How do you communicate to your boss about your disease or to your direct environment? But also all the understanding even more about the disease, because we know patients with high literacy also have better outcomes. And the second thing that patient organizations can offer is that we have the collective intelligence of all the patients living with that disease. So we do surveys among our members, we collect data among the members, and based on that we can find the gaps in the system. We know which hospitals have better results. The question is, why do they have better results? We notice that, we have data, we have statistics. So work with us, and I think we can improve a lot for patients and for the system itself to gain efficiency.
Thank you very much indeed, Stefan. Professor Salmi, Stefan made a really good point there. Different hospitals seem to have different results. Why is that?
Yeah, that was very interesting point. I think personally it's very difficult to fastly respond that because I was amazed of hearing that, and very happy. And this is especially what the patient associations and patients can really see better, because we doctors, I think we can rarely see in that way that, and it might be related to personal contact with a doctor, that sometimes the communication is better, so their personal characters, but also I think there might be in the how the hospital has adopted the recent results of the research and use them. But it's a combination. It's very important that the patient is taken care as a whole, like my other colleagues also pointed out, and all problems are taken care of.
Thank you very much indeed. So, Professor Salmi, very clear there. Perhaps I can bring in Professor Cardell now. Would you like to add anything to that? Clearly, we're seeing different results in different hospitals, in different centres of excellence. Are we actually treating patients as a whole?
Yeah, I think all centres can do the talk, but few centres can do the walk. And the greatest barrier is the economy and where the hospital, sort of the management, decide to prioritize. Because multidisciplinary care, and especially a global care with all this system, costs definitely more money when just managing the sort of set of scale for a single symptoms. More doctors involved, more caretakers involved, more time to listen to the patients and patient organization cost more money in the short run. So somehow we have to show that it's more money in the short run, but for the society as a whole, but not for the individual clinic or so. It's a good investment that will earn money in the long-term period, but unfortunately not for individual clinics, and perhaps not even for individual hospitals. And that's the problem. According to me, at least.
Yeah, no, it's a great point. I want to bring in Professor Smith. Clearly, we're hearing a great deal from a European perspective. You are a long way from us here in Europe. So would you agree with all of that in Australia?
I think absolutely. There's a whole range of factors that have been touched upon, as Professor Salmi has suggested. How engaged the doctor is can also reflect how enthused the patient is to treat. We have a lot of variation in waiting times in health systems, and that can affect burden of disease and quality of life. We have different expertise in treatment of polyps. Some people will do will have expertise in doing quite widespread resection. Some will do minor debulking. Some will do post-operative steroid wash treatments. Some will do pre-operative steroid treatments, and there are now biologicals available in some cases. But so there's a lot of variety in care, and that probably reflects a large range of differences across the countries surveyed.
Well, let's talk to a patient. Nellie Clays, let's bring you in again. I mean, it doesn't seem rocket science to me. Surely we need to involve the patient more and more, don't we? Because we need to learn from patients.
Yes, but I'm very happy that I hear from the medicals today that they say it's important to have a lot of time to listen to the patients. I think that's the first point. Then after the physical symptoms, there are always other symptoms, emotionally, psychological. It's very important to listen, and then I think when you have the whole story around the patient, you can do a lot.
Fantastic, thank you very much. Well, perhaps I can ask a tricky question to then Professor Salmi. I mean, clearly there is a huge economic burden. We heard from Professor Cardell about that. And obviously the quality of life, the burden on patients. I kind of want to ask, why haven't we done more sooner?
Very good question, indeed.
Thank you.
I think I don't have a correct answer of that, but we should have done this much before. But I'm anyway very happy that it seems that we are now taking these steps very, very actively, not just on type 2 diseases, but on all diseases. And definitely this should have been started much earlier. But I'm so happy we are now.
Well, absolutely. I just want to ask Professor Cardell the same question. Why haven't we done more faster? Or do you think we've done everything that we could at the time?
It's probably a question of emphasis and interest, and there had been a lot of interest within the separate specialities, and perhaps not enough incentives to create interdisciplinary interaction, and especially I come back again to look beyond the symptoms of the organ of a specific clinician. So this is probably a general trend also in the whole society to have a more holistic view of things, and that affect us in medicine and that benefits our patients.
Yes, indeed. Stefan, perhaps I could bring you back in here as well. I mean, obviously we're talking about multidisciplinary care. It all sounds fantastic. In your view, as an advocate, do you actually think it's going to be possible? Is it practical?
Yes, and it must be done. And it must be done by type of disease, so that we can have disease management plans or treatment plans from early symptoms to the end of treatment. But looked at not only from an intervention or technology or infrastructure perspective, but really looking at it from a systems perspective. And I think when you involve patients and massive amounts of patients with all their outcomes data, you can see where the best practices are. You can identify why things get better in one place and not in another, and how you can learn from it. And I think you need a multi-stakeholder and multidisciplinary observatory to manage that process by type of disease. And I think EUFOREA could play a great role in that for airway diseases. But I think this is the way forward, not only here, but also in oncology, also in other diseases. Involve the different patients, listen to what's happened to them. Outcomes is not only the result of clinical interventions, but also lifestyle activities, literacy and mental low social isolation and mental well-being. So all these aspects have to be taken into account fully so that the patient can really have the best possible outcome. And I think that can only be done by having, listening to everybody, listening to all the different perspectives, bring them together, and then to track progress based on dashboards that have been established together.
Super, thank you very much indeed, Stefan. Let me go to Professor Smith now. Stefan speaks very passionately there. Clearly, it depends on the country you're in, doesn't it? And in Australia, I'm just keen to know, do you believe that multidisciplinary care is feasible? Is it practical? Are you doing it?
Certainly, that happens from the GP level. As an allergist, I'm involved with my ENT colleagues. We share patients. We share both medical. They ask me to do a large amount of the medical care, and they do the surgical care. And if I'm not winning, that's when we'll get help. It's important to be involved in these organisations professionally as an allergist, to be having that frequent engagement so we can have best care. But that is not standard of practice for most of my allergy colleagues here in Australia. Some are active members of rhinology societies, some aren't. Some have focus on atopic dermatitis. These diseases are so specialised, it becomes very hard to be an expert in everything.
Yeah, no, very, very wise words indeed. Let me just bring in Professor Salmi. So obviously we've heard Professor Smith there talking eloquently, but given the action items from the white paper, what do we do now? What are the next steps? What do you want to see happen right now?
Right now, I would like to see that there are either physically and or kind of in a paper or in a plan, a scheme or the kind of learning kind of what is it pathway when the patient enters the hospital. So what if there seems to be a disease of another specialty, what to do, where to enter, so that it's fast enough. And also this should be, of course, started from pharmacist or pharmacy and primary care. So at least in a paper, but in the best thing, it's already in the hospital care. So that. And then a clear-cut feedback and always feedback from patients. Is it working or not? What can we do better? So that patient really feels safe and hopeful. So that despite a chronic difficult disease, there is reasonable quality of life, so good as possible.
Can I bring in Professor Cardell now? Would you like to add anything to that? That was great from Professor Salmi saying, what's working, what isn't working, what we do about it now. What would you like to add?
Yeah, if I had one wish that could be granted, it would be a simple thing, a different algorithm of reimbursement for multidisciplinary care. That would, at least in my hospital in Stockholm, Karolinska, change the playfield directly, because if there is an economic incentive to work together, I think that will sort of make it possible for colleagues to do it and work around the patient.
That's really interesting. Professor Smith, is it about money? If we throw money at the problem, does the problem go away?
I think better dialogue is important. I don't think money is the total answer, but it's certainly part of the system that drives organisations and drives organisational change. There's, I think, in care and health systems, there's always dollars, egos, empires and politics. Who owns the disease? I think we're now agreeing that diseases are best managed as a shared. So those empires and politics are not there. I think egos rapidly disappear when we think of patients first.
Yeah.
And the dollars, as has been raised, are important to get the teams talking together for the best patient outcomes.
Very well said, and a very good place to wrap up this particular section. Thank you very much indeed to all of you for your thoughts on how we do that, how we improve multidisciplinary care, interdisciplinary collaboration, and how we move on from here and the steps that we need to take. I just want to come back to each of you, if I may, because obviously we've covered an awful lot of ground. We've talked about the white paper, we've talked about the findings of the white paper, we've talked about the actions, how we move this forward. And Professor Smith, I thought, made a great point. It's about the patient. So let me come to you, Nelly, as the patient. What, going forward, do you think we should do? What are your thoughts about where we are on this journey?
My dream is that there is some medication that helps me from my asthma and my polyps. And I have also a dream when I go to the hospital that there is a place, multidisciplinary, that I can speak my ENT doctor, that I can speak my pulmonologist in the same time.
Yeah. No, absolutely right. Let me bring in Stefan here. Obviously, Nelly speaks very passionately there about wanting to see everyone at the same time, that her symptoms get better. As an advocate, where do you think we are on this journey? What would you like to see done from here?
Well, maybe, as I said before, I think it's important that people listen to each other, and I think education is critical, education of the patient, but also education of the medical teams. They have to understand what the patient actually lives through, what the consequences are of living with the disease, of living with the treatment. Very few people have actual understanding of what it actually means. So I think educating each other can make things move forward in a significant way.
Very good, educating each other. Professor Salmi, would you agree? What else what would be your sort of final thoughts in terms of where we are, where we're going, and where we are on that road?
We are going to more and more, and I think the departments that there are different specialists working probably in the same corridor, and the patient really can, during the same day, if it seems that there is now an acute need to see also the other specialists, so it would be flexible and possible. And of course, there, on the other hand, might be also some virtual seeing patient virtually, or a kind of feedback via mobile, or we should use these digital possibilities much better. And then the education of the doctors by virtual connections should be global and multidisciplinary, like together with patients. And this will be increased much more in the forthcoming months, and has been seen already, which is very good.
Professor Cardell, I mean, clearly you're doing fantastic work at the Karolinska Institute there. Just in terms of your knowledge, are different European countries doing this differently? Do we see great care in one country and not so great care in other countries?
I think the systems are different, and some countries are definitely ahead of other countries, and so there is a difference in the sort of global awareness of the problem, and I think it's important to be able to argue that we have to sort of change our organizations, especially in those countries with sort of not so good outcome as the best ones. But of course, probably the best ones is characterized by better organization. But to argue for organization change, we need to have more research that's suggested in this white paper of the benefits of the global multidisciplinary approach, because sort of hard scientific data make it possible for us to argue for a change.
Thank you very much. Yeah, thank you very much indeed. Professor Smith, I mean, clearly, obviously, different countries, as Professor Cardell was saying, are doing things differently. There are different systems. We need to learn from each other. But actually, isn't that why the role of EUFOREA is just so important? It's a global organisation. It's bringing all of you together and it's sharing best practice.
It's shining a light on where deficiencies are and where there are opportunities. And rather than just saying, here are the problems, it does actually give some opportunities for discussion about the ways forward. I'd like to sort of reinforce the point that we do work in our own channels of knowledge. And those channels are not enough. We need wider channels. We need to know what our colleagues know. And I think if we do these multidisciplinary clinics together, we can actually be cost effective. Not only for the hospitals, we can provide better care, but there's a cost to the patient. They miss a day of work to attend a clinic. So there's benefit for the patient and for the community and the better care. And EUFOREA, I'd like to say they're a vehicle, but I think they're now getting they're a convoy. There are multiple vehicles of bringing attention and to the issues involved in inadequate treatment outcomes in type 2 disease, involving the patient needs, patient organisations, getting information out to specialists, and also that information to people who have influence on political decisions, both at the hospital and government level.
Fantastic. Very wise words. Great place to end with. I love that. EUFOREA is not a vehicle, it's a convoy. Thank you very much indeed to all of you for your thoughts. Well, sadly, that's all we have time for. Many thanks to my panel for what were amazing comments and thoughts. It's been really fascinating debate, and I really want to thank you all for being so candid. Many thanks indeed to all my guests, to Nelly Clays, to Stefan Geisels, to Professor Salmi, also Professor Cardell and Professor Smith. Thank you to all of you for watching this EUFOREA Innovation Debate on improved coordination of care in type 2 inflammation. Now, I hope you found it extremely useful, informative, but most of all, I really hope you'll take forward everything you've learned to improve care for patients around the globe. And you can find more information about EUFOREA and register for the EUFOREA meetings on the euphorea.eu website, where you can also sign up to receive the latest news via email. And of course, don't forget to follow us on Twitter for all the latest news and information. The address is @EUFOREA. From all of us here, until next time, goodbye.